Cataract extraction using phacoemulsification is a routine procedure, but in this particular case, the patient presented with pre-existing central corneal opacity because of the varicella zoster infection when the patient was in childhood. So here is how the surgery was performed. Patient is made to lie on operating table. Proparacaine iodine is instilled topically on cornea. Eye is cleaned externally with iodine. Universal eye speculum is placed. Side port is made with 15-degree lens tip at 3 o'clock position and at 9 o'clock position. Anterior chamber is filled with balanced salt solution. A trypan blue dye is injected to stain anterior capsule. Following 20 seconds, dye is washed using balanced salt solution. Cornea is covered with viscoelastic substance to protect it from dryness and for enhancing visualization. Viscoelastic substance is also injected into anterior chamber. Using a cystitome made from 26 gauge needle, continuous curvilinear capsulorhexis is made on anterior lens capsule. Central corneal opacity, it is necessary to have a large capsulorhexis to make use of clear peripheral cornea for easy nucleus manipulation. Doing capsulorhexis in central corneal opacity patients requires a great skill, precision and experience. Now, a superior clear corneal incision is made at 12 o'clock position using 2.8 mm curetome. Hydrodissection was then carried out, separating the nucleocortex material from capsule. Viscoelastic substance is injected into anterior chamber and on the cornea. Nucleus was rotated within the bag to free it from its adhesions. Using a direct chop technique, the nucleus is phacoemulsified and aspirated. As the central view is obscured by pre-existing corneal opacity, phacoemulsification of the peripheral cortex ensures that the central portion is also phacoemulsified, making use of the peripheral clear cornea and thus preventing a posterior capsular rent. The nucleus was skillfully chopped, emulsified, and aspirated. It was made sure that the phacoemulsification was done using as minimum energy as possible because the cornea is already compromised. The remaining cortex is aspirated using Simcoe irrigation aspiration cannula. After placing an anterior chamber maintainer, superior clear corneal incision is extended using 5.2 mm extension blade. A rigid PMMA intraocular lens is placed inside the capsular bag. AC maintainer is now removed and the main wound and the site wound are sealed by stromal hydration.